You know, with the proliferation of heart valve clinics, we have these patients coming through the clinic all the time that don't have aortic stenosis but have aortic insufficiency. They're often high or prohibitive risk, and the teams are saying, what can you offer them? But we have trepidation about treating these folks with transcatheter aortic valves. The annuli aren't calcified, the root is dilated, may be prone to injury. Oftentimes the ventricle's thinned and dilated, and so the consequence of any procedural missteps is magnified. But I would submit that there is an unmet need for this kind of population. And if you look at the survey from Europe that was published about 8 years ago now, you realize that patients with severe aortic insufficiency do not receive guideline-based surgical valve replacement in a lot of cases. And the incidence of valve replacement declines as the ejection fraction does. So we've all seen the slide at the advent of TAVR about the unmet clinical need, the 50% of patients that weren't getting aortic valve replacement. I believe the same thing exists for aortic insufficiency. And then some of this was reviewed earlier, but the outcomes with transcatheter valve replacement in this population haven't been great. The most recent, as far as I know, was from the group at Penn that looked at the TCT registry, or the TVT registry, and they identified patients with mean gradients less than 20 and moderate or greater aortic insufficiency. And what they shared with us is that about 1 out of 4 patients required more than a valve. The length of stay was long, 30-day mortality was high, and a number of patients, about 1 in 6, were left with at least moderate aortic insufficiency. And those outcomes are similar to what the multi-center registry from Europe established with CoreValve. Procedural outcomes are worse, and patients don't survive as well. As was alluded to earlier, there are valves now specifically developed for and in early clinical trials for aortic insufficiency, and both of the valves that I'm aware of that are designed specifically for the condition make use of an anchoring mechanism, and obviously this is to circumvent the lack of calcium in the annulus. This is the Jenna Valve. The Jenna Valve has paper clips or anchors, whatever you like, that goes into the cusps of the leaflets, and as the valve is deployed, it grasps the cusps and tethers them to the valve prosthesis. The results from the earliest use of this were reported at EuroPCR this year. You can appreciate these patients are appropriately at least high surgical risk. And the outcomes with this valve were pretty good. 30-day mortality was 0. It wasn't in the range of 25 or 30%, and most patients, or nearly all patients, had a pretty good hemodynamic result. There was one conversion to open surgery in this series, likely because of valve embolization. So what I'm going to share with you is a case that we recently did, not using the Jenna Valve, but using the J Valve. And I'll show you a picture in just a second. This was a 75-year-old male that had severe aortic insufficiency when we met him. Now, in 2004, he had an aortic root and valve replacement with a freestyle root, and it lasted for a long time. He did really well after that valve replacement. The gentleman has a vacation home in Cabo. He loves to deep sea fish, but his post-operative course, even in 2004, was pretty rough. He limped. He couldn't get the sternum to heal. He was in the hospital for a long time. And then when we met him, he had been admitted 6 times in the last year for heart failure. And that was accompanied by a decrement in his ejection fraction. So NYHA class 3, a number of heart failure hospitalizations. I had some trouble with the videos this morning. I'll apologize, but I will share pictures. And so these hospitalizations corresponded to a decrement in his ejection fraction and severe aortic insufficiency across the prosthesis. Came through the heart valve clinic. We did the CT scan. Of course, there's no calcium in this root. But it was a discussion about whether or not to refer for palliation or to try an off-label use of a transcatheter valve, and so we did. This is the core valve, or a core valve that we tried. Obviously, this is off-label for bioprosthetic aortic insufficiency, and we put the valve at 3 millimeters below the annulus. We deployed the valve, we stepped off fluoro and sort of congratulating ourselves, and stepped on to get the aortogram, and the valve was in the root. So we're like, okay, let's try again. Deployed the valve 6 to 7 millimeters into the LVOT, stepped off the fluoro pedal, went back on. Again, it was in the root. It just wasn't fixing to the annulus. So before releasing, of course, we pulled the device out, closed the leg, and called it a day. At that point, we were aware of both valves in the space. The one that we were more closely related with was the J valve. This is produced by JC Medical. It's been used in China a fair amount, and then John Webb in Canada has done probably 10 cases, I believe, at this point. And so we went through the IRB, we went through the FDA compassionate use pathway, and we were permitted to use the J valve in this patient. You can see it shares some similarities to the Jenna valve, right? You see these clips, these anchors that exist outside the valve. Again, these are intended to tether the native valve to the prosthesis. And what I've done here is shown you a picture, again, no video of the valve. You can see the way it deploys is you place the anchors into the cusps. You hold a little bit of forward tension to be sure that the anchors are right at the base of the cusps, and then you advance the valve and it deploys inside those anchors, again, tethering the native leaflets to the valve prosthesis. So not only are you able to anchor a valve without calcium, but this does offer the advantage, the necessity of commissural alignment. So we're going to learn a lot about whether or not that's relevant from a hemodynamic perspective as experience with this valve expands. His aortic insufficiency was obliterated immediately. The procedure went very well, and my clinic nurse texted me this morning. He was back and gave permission to show he's back in Cabo deep sea fishing. Nice. So doing really well. I got permission on the phone for this, nothing written, so don't hold my feet to the fire. Anyway, so these prostheses are coming. The series that is grown to 12 now is going to be presented at TCT, primarily for native or bioprosthetic aortic insufficiency, but there also may be some utility in patients with low coronary arteries, and we've submitted for another case, valve in valve, where the left main is 2 millimeters above the surgical annulus, and perhaps by tethering the leaflets to the prosthesis, we'll be able to make some room for coronary flow. Thank you very much.